the certificates will be provided at the IPCA stall situated on at the outside of the conference hall. Let us proceed to the next academic session with renewed energy. The geriatric mental health care has its own set of complexities which will be discussed in this session on establishing geriatric services. I extend a warm welcome to Dr. Chandrasekhar, founder and managing director of Asha Hospital. Welcome, sir. I now welcome Chairperson Dr. B. Anand, sir, Professor and HOD Psychiatry, MRI-MS, Hyderabad. Welcome, sir. Akanksha Sonal, ma'am, Assistant Professor in the Department of Geriatric Mental Health at King George's Medical University, Lucknow, UP. I hand over the dais to the chairpersons.
Good afternoon. I think people are trickling back slowly. Anyway, as in the last few years, the concept of subspecialization psychiatry has been taken up, and several places it has gained some sort of a traction. I don't think right now any single psychiatrist can say that he can deal with all types of or all branches of psychiatry. More so, we have seen as the lifespan is increasing, there is more and more number of geriatric population which are coming with various behavioral problems and psychiatric problems. One of the essential things in geriatric psychiatry is that that is where there is more of a liaison with the physician and the neurologist and other branches of medicine also takes place. So a geriatric psychiatrist should be well versed not only with psychiatry but also with general medicine, neurology and other aspects, other medical specialties. I had an opportunity to visit the geriatric psychiatry department in Lucknow way back, maybe about when it was established, in fact, when it started, and it is a very nice sort of a department, and I think which has grown over the years, and right now they have even DM in geriatric psychiatry, and we have here Dr. Akanksha, who is a faculty there, and I request my co-chairperson to introduce Dr. Akanksha.
It's my privilege to introduce the speaker of this session today, Dr. Akanksha Sonal. She is DM Geriatric Mental Health from KGMU, Lucknow, MRC Psych, Royal College of Psychiatrists, UK, CAPE Fellowship from Cambridge University, UK. She has fellowships in palliative care, health policy and systems and research. She is currently working as assistant professor in the Department of Geriatric Mental Health, KGMU, Lucknow. Her special interests are in positive mental health, behavioral problems of adults and old age, mental health law and policy. I invite Dr. Akanksha Sonal to kindly deliver her lecture.
Session. Myself, Dr. Akanksha, and at the outset, I like to thank the organizer. I'm such a, I don't know, I feel like I need 20 more years to stand here and talk about geriatric mental health, especially if I'm talking in front of Chandrasekhar sir. And thanks to Ashok sir and Neha for coordinating and calling me here. And my alma mater, which has got me the spark in working for mental health of especially the old age population. I am trained in MBBS from Madras Medical College, which has a legacy for geriatric care. The father of gerontology belongs to Madras Medical College, V.S. Narayan sir. So there itself in my second year MBBS, I got interest like this is a specialty where I belong, the old age and then mental health. And gradually this built up with me when I did my MD in psychiatry. There also I worked in old age psychiatry. I did my MD thesis in risk of self-harm in older adults, not adult population, just focused on 60 years and plus. And after completing my MD in psychiatry, I joined DM in geriatric mental health at KGMC. And now I'm working as a faculty, dealing with older adults day in and day out. So, what is geriatric psychiatry? I'll be covering my presentation because where in all, talking about establishment of geriatric mental health or geriatric psychiatric services, we provided every setup. I heard a very nice line from a geriatric psychiatrist while having a session in American Psychiatric Society. There she said that everyone is a geriatric care provider at present. Be it a physician, be it a cardiologist, be it a neurologist, majority population they are catering is 60 years and plus. Apart from pediatrician, we can say every other professional is a geriatric care provider in some way or the other. So what is the problem statement of this population? What are the challenges? When we say that we are a geriatric care provider, what are the needs of this population? What we do, how we do, and what are the successful management strategies, challenges, and then we are open for discussion. So talking about the problem burden, I don't know, being an older psychiatrist, I keep dwelling with numbers. So if I talk about 2011 Sensex, 2011 Sensex is what, 8.6%. If I go in 2023 Sensex or 2022 Sensex, it's 10.8%. And the way it is growing, it is expected that by 2050, the older adult population will be 21%. That is 1 in 5 gonna be 60 years and above. So you can imagine what kind of infrastructure, what kind of trained staff we required and services we required to provide them. And this is the growth rate, how the older adult population are growing. If we talk about the general population, it's falling from 90 onwards because we have improvement in our healthcare, our infrastructure, our economic capacity. So our general population is falling and older adults population is just multiplying at 40+%. Talking about Telangana, because this belongs to in the lunch break itself, Ashok sir was telling me what is the per capita income of Telangana, and it comes with a baggage of older adults population which comes with multiplicities. So it's right now it's 11% and expected to be 17.1%. 17 means again 1 in 5 by 2036, which is not so far. Talking about aging index, and by aging index we need to know that how many older adults per 100 children we have, because that's how we calculate the dependency ratio, how many work staff we are having to take care of or cater that coming booming population of older adults. And that is Telangana comes under southern states with a aging index of 61.7, and that is in 2021. With booming population, you don't know in the coming days how it's gonna be. So there was a very nice title I saw in Hindu in 2019 where they have, in 2019 itself they have written, geriatrics is the new pediatrics. And then again in 2023 October there's a United Nations population report came and stating that Telangana's elderly population projected gonna be 17.1% by 2036 and how we have to prepare for that. So challenges of aging, as I said that there is a south-north divide, and this is basically how the health sector is better, literacy is better in southern states, and that comes with a burden of elderly population. Feminization, the majority population is females. Ruralization, still majority of our older adults belong to rural India. Aging of the aged, and by aging of the aged it means because of increasing life expectancy, if I'm telling that 60 plus is aging at the rate of 40% plus, the 80 years and above are increasing at the rate of 200 and plus. And you can imagine what the burden on health sector it will come up with this kind of population. Decline in health status, because obviously we are increasing in numbers, but morbidity is coming as a package of it. Economic insecurity, compulsions, lack of access to quality healthcare, financial dependencies, because most of the older adults, what we are seeing right now, they have worked in unstructured or unskilled labors, and now they're going back to their home, that is rural India. And they don't have access, they don't have financial dependencies. Social exclusion by virtue of being aged. Then digital divide. There's so many techniques we are talking about, how good the telepsychiatry is, but we know the struggle of getting a telepsychiatric consultation, getting done with an older adult. Then who are we, a geriatric mental health care provider? So as by definition, this is a subspecialty dedicated to treating and caring for individual age 60 years and above for India. Basically outside is 65 and above, because our Ministry of Social Justice and Empowerment for every reasons considers 60 years and above as a senior citizen or older adults. 60 years and above with mental health problems, we provide comprehensive assessment, treatment to care, emotional, physical, social, and cognitive needs of older adults. Biologic, as I told you before itself, apart from pediatrician, everyone provides care to geriatric care patients somewhere or the other. So if I go through the structured training programs, there are only 2 centers in India till now who are providing structured training in old age psychiatry. I belong to the first center where the training in old age psychiatry started way back in 1999. When my former head, S.C. Tiwari sir, came back from US, and then he got the idea that he should have a focused, dedicated older adults unit. He started that in 1999, and then it became a unit in 2003, and then 2005 we have a separate 30-bedded setup. And in that setup, we are having fellowship courses from 2008 onwards and DM courses from 2011 onwards, parallel when NIMHANS started their child and adolescent courses. Gradually, geriatric psychiatry unit at NIMHANS also started to get in pace with geriatric psychiatry functioning. And here we see Matthew Verghese sir, who is leading the geriatric psychiatry setup in NIMHANS. Now he's retired from there. And they have fellowship 1 program from 2014 onwards and DM from 2017 onwards. So what are the advantages of having a subspecialty or working in a subspecialty? So there you tend to see a specialized population. You tend to see, and you are able to cater to specialized needs of that population, which you tend to ignore or miss when you are seeing a general population overall. Then this kind of support and resources required, as Chandrasekhar sir told in the introduction, the geriatric psychiatry or geriatric any setup, being in geriatric medicine itself, it's a lot of how good you are at listening, how good you are a detective in identifying the problems. You have to be a psychiatrist, you have to be a semi-neurologist, you have to be a physician of some kind to identify nits and bits what is happening with the patient. Timely interprofessional assessment and recommendation follow-ups, that is your interdisciplinary approach. Avoid unnecessary hospital admission, because it will come with a burden. First of all, 1 patient will require 2 attenders, especially in Indian setup where patient have to get admitted with an attender, they can't, elderly especially. And then there is an increased risk of fall or any other hospital-induced infection. So we try to avoid that, and that we can do with timely assessment, timely referrals and follow-ups, working towards integrated system of care. You just can't, in geriatric psychiatry, you just can't work in silos. Like in pediatrics, in child and adolescent. You need a team, may not be in-house, but at least you have a proper referral mechanism in place. I'm working in a tertiary care setup, so I need not to think about it. I have a geriatric medicine department, I have a neurology department in place, cardiology department in place, trauma and emergency in place. But when we are practicing, there's no harm in having a close contact with your other specialty friends, where you can cross-refer here and there when required. And this gives you opportunity for interprofessional education and research. You come to know what is happening there. Like if I'm discussing 1 patient who is having some cardiac problem, he's having anxiety. When I worked up, before they said nothing, there's nothing, they didn't find anything on ECG. Then I said, no, but I'm not able to think that his anxiety is functional. Then again, they went and did a 24 hours Holter, and they find some ectopic patterns in their Holter. So this gives you opportunity when you liaise with your colleagues that what's new can happen. You can give them some information and collect back some good information for your future. What we see common ailments as a geriatric mental health professional. If I divide my OPD itself, like Saturday I had my OPD yesterday. So I saw just 25 follow-up patients and 5 new patients. And if I divide them, it's very easy. There were 6 were dementias. Out of that, as the numbers follows. 3 were Alzheimer's dementias with behavior problems or coming out of the behavior problems. 2 was frontotemporal dementia, one was typical frontotemporal, that is behavior variant, other was language variant, and one was DLB. I was following a chronic case of delirium, having delirium on and off for the past 1 year. And finally, when I correlated every bit of history at the OPD basis, we came to know, okay, it is DLB and sent it for PET scan. Then the 8 patient of mood disorders, that is depression you see, bipolar follow-up for 3 patients, and then delirium we tend to see, 3 or 4 delirium follow-ups we see. New patient, again the division is same, 2 cases of cognitive impairment which are under follow-up because we don't diagnose individual with cognitive complaints, dementia at the first visit. We need to work up, detail, collect the history, do the workup. So 2 individuals with the complaints of cognitive deficit, 2 were acute cognitive deficits, and 3 were again having affective symptoms. Talking about the burden, the last data we got on older adults burden was 60 years plus was LASI data, which we're talking on and off in geriatric setups. And talking about their data, they are telling that 30% of older adults are having depressive symptoms. Out of that, 8.3% are having major depression. It is not glaring. Glaring is that only 0.8% know that they are having depression and are on treatment for that. That is, we can imagine what a great treatment gap is there in older adults. So how are their needs different with due focus on cognitive and mental health? I like this phrase that's rightly said by Mark Twain. Age is just an issue of mind over matter. If you don't mind, it doesn't matter. So for most of the older adults, they do really well till late in the life. It's just there was bits and pieces of cognitive changes which you expect out of aging. Like there is slowness in retention of new memory. There is a deficit in this processing speed. But we always have to give the credit to the wisdom they have gained over the time. Other problems, if we talk about the personality trait, the mental health problems, suicide, substance abuse, what we see in substance abuse in older adults is benzodiazepine dependence and painkiller dependence. And it's very hard to manage that on OPD basis. And as far as our understanding, as they age, people are generally more satisfied with their lives and more optimistic about growing older. What we do, as I told you, that geriatric psychiatry is more about a teamwork. I am an anchor, but that doesn't mean I am the one person who is doing everything. I need a team to support my planning. So I'll be a psychiatrist who's, if I'm getting a new case, I'll be working with my resident who's taking the detailed history or I'm doing a follow-up. Then a clinical psychologist, preferably a neuropsychologist who's then and there to help me whenever there is a diagnostic dilemma or workup issues. Then a mental health nurse who is interested in working with older adults, because there is very different kind of problems a mental health nurse sees in an adult psychiatry setup compared to when they see in an older adult psychiatry setup, where we will be asking them to take BP every 2 hourly, every 4 hourly, especially if I'm admitting a delirium case. Then social worker. There's lot of things are there which a social worker need to cater in a any setup for. Like lot of social security schemes are there which they will be guiding to the patient, because most of them, they don't know what benefits, what provisions are there. Like the Upadhyay scheme is there. Like lot of provisions are there from the government side. You can get lot of physical aids, you can get water mattress, water beds, air beds. So many schemes are there, which it's not possible for me as a psychiatrist to tell every patient, which my social worker can sit at ease and can explain them about how they can get access to this Ayushman Bharat, how they can get admitted under that, get the full workup done. And because everything is inpatient basis, mostly in whatever the government-based insurance schemes are. So we need a social worker who is trained and ready to work dealing with all these things. Then a physiotherapist, because obviously every older adult has some bit or the fall, balance issues, So we have a physiotherapist in-house who is taking care of our outpatient and outdoor patients and indoor patients. Occupational therapist. Now I'm admitted a patient for depression. Now I have to plan full day. What he's going to do staying in the ward, apart from taking medications. So I need to have a structured schedule for him and how he can manage his schedule at home also. So we have an occupational therapist who sit with the patient and design for them. Then a nutritionist. We have an in-house nutritionist from the department who will go and see each patient. They assess their frailty assessment or what kind of weakness they are having, sarcopenia, frailty, failure to thrive, and decide their diet regimen. And it is very interesting that last month I saw a patient, an 87-year-old gentleman who came that he was very well. He was cognitively no complaints. He just said that for the past couple of months, I can say that I'm not able to walk that much I usually used to walk. Previously, I was able to walk 5 kilometers with ease. Now I'm feeling a bit weak. Can you have a nutritionist? I want to meet a nutritionist, a specific, focused. I don't want you. It's okay, you are coming as a package, but my attention is, can I have a nutritionist? So we need a nutritionist working with the older adults, then a physician, a spiritual counselor. You can have a varying kind of requirements in older adults. So they also are very helpful for us. And they help with other palliative care services also. It's not that the spiritual counselor is only for us. Then palliative care. Now the issue is, there's very less when we talk about geriatric palliative care. Palliative care we synonymize with like what? Oncology, cancer and palliative care. But it's very important to discuss palliative care in dementias, especially advanced stages of dementias. We really don't know when to start telling no, when to cut off things, when to start cutting off like, yes, now you have reached, this is the course which I'm explaining you for past 8 years or 10 years, like this is a progressive neurodegenerative conditions. It will go through stages by stages. There will be mild, there will be moderate, there will be severe. On and off, you will be having behavior problems, which I will be there to guide you, to help you, to support you, and get you out of it. But then there comes a time that we have to, like, okay, now we have to move from preventive, curative to quality of life. Be it from pain, be it from agitation, be it from how best we can calm him down, how best we can avoid frequent admissions for UTI, for not able to eat properly, for not able to pass motion properly. So that is very much required or integrated with older adults care. Then, and in whole journey, the most important anchor of care is your caregiver. And how much we are taking our caregiver in confidence with us while planning the care. And that too from the beginning, from the day one, your journey will be as smooth as possible. So what we do as a geriatric mental health, we don't have a separate memory clinic or others. We have a single free movement older adults clinic. Anybody can come with 60 years and above, can come register with us, and we'll do a detailed assessment. We generate general evidence-based support for him, psychoeducate about the diagnosis and follow-up. So how we like to clinically evaluate? Obviously, there are two platforms as been discussed, as face-to-face or telehealth. But it's very difficult to examine older adults, especially in the first consultation over virtual mode. So we prefer, because we don't know, at times the attenders even don't know the history of fall. If I'm seeing the patient face-to-face, I can make out there is some injury. There is something glaring at me, that there's something, some suture line or some blood deposited there. That may help me diagnose that it might be a fall, it might be a stroke, it might be a seizure. So we prefer first consultation face-to-face. Follow-up consultation can be taken on e-Sanjeevani. As I'm working in a government setup, we have an e-Sanjeevani platform working since COVID. Then our focus areas of interview is usual. What are the chief complaints that someone is coming with? How this complaint started? What was the reason behind it? Then what are the associated complaints and how these complaints are impacting the older adults in their life, be it instrumental activities or activities of daily living. Once my detailed workup is done, usually for older adults, my first consultation is about 40 to 45 minutes. You just can't cramp a 60 years or 65 years of history in 15 minutes. I don't think so logically it's possible. So it takes like 40 minutes, 45 minutes for my resident to work up. And then we'll be planning that what my provisional diagnosis are, and then according to our provisional diagnosis, we will be designing whether it requires a delirium panel workup, depression panel, psychosis panel, or dementia panel. There was some subtle differences. If I'm talking about delirium, my mind will go for any UTI, any chest infection, any fall, or acute TIA. So I'll be doing like that, CBC, simple hemogram I can make out any infection. I can do electrolytes. Hyponatremia is very common in older adults. Similarly, I can do a UTI, urine RM culture sensitivity. Easily I know this is an infection, this is a antibiotic panel I can start on, right? And if I'm suspecting something acute, syncopal, seizure, then I need to go for a CT scan. Depression, when I'm talking about depression in older adults, we do always go for a thyroid profile, a B12, vitamin D, and a homocysteine profile. Psychosis, again, B12 usually get associated with psychosis. And late onset psychosis, we tend to get a CT scan as well. Dementia, primary level panel is same. Then we do, because I'm working in a tertiary care center, so I have privilege of doing specialized neuropsychological assessments. We have neuropsychologists, 2 neuropsychologists working in my team. But it's not necessary that you have to have a detailed neuropsychological assessment for every case. Majority you can handle at your own level with a MMSE or ASH, which you can do. MMSE will take 5 to 10 minutes and ASH obviously it will take some 20 minutes. Right? Detailed neuropsychological assessment is required when there is a diagnostic uncertainty, there is a differential diagnosis, young onset, some gross disparity in presentation and functional impairment, speech and language deficits. Then we do special tests, PET scan, lumbar puncture, genetic testing, blood-based biomarkers, but then rare is always rare. The case-to-case requirement and not required for routine practice. What is important here in geriatric psychiatry is multidisciplinary team meetings. Try to have your team, like the neuropsychologist you are working with, the physiotherapist you are working with, the physician you are working with. Try to have a set day in a week where you can discuss what kind of cases you are seeing, what progress they are making, or they are not making any progress at all. This was not good for that case, but in future also, if you see some different case or difficult case, it will guide you to plan your management. Basically, we do MDTs for these kind of situation. If you have problem with the results, I'm not able to coordinate, link the complaints and the results I'm getting. Imaging, I'm expecting something in line of Alzheimer's, but I'm getting imaging something different of DLB types. Consensus diagnosis, I'm not able to fit in a particular diagnosis, which happen quite frequently. There is a medical comorbidity issues running on, support issues, client strength and weaknesses I'm not able to understand, and I want others to give their feedbacks on how to plan, because in geriatric mental health, there's no clear-cut guidelines, what drug to use, how to use, in which condition to use. So there, it's nice to have a multidisciplinary team meeting and get the consensus feedback. Okay, I need to start on antipsychotic because the behavior problems are more than usual, and it is dangerous for the patient to start with. Then we can plan for cognitive interventions, and then most important is legal and financial issues. You tend to get, and as everybody has told you and guided you all, that with every case, sense that that can land up in a potential medico-legal complication. So with every case, we have to be strong with our documentation, how we are handling, how we are talking. Try to have limited conversation, giving a wrong prognosis. So restrict ourselves then and there where it happened. And involve the team. That will also help you when you have any legal issues coming in future. We tend to get oftenly that patient went and said, somebody went and said to the magistrate that my land was taken by someone by false pretext. Now give me a mental certificate, or get a mental certificate for my mother or my mother-in-law that she was not in a mental well state and somebody falsely got signed from her. So it's these conditions we see often, like once in 3 months we see some cases like that, where magistrate is also not very clear what they want. Police also don't know what they want, but they just send to us. Then communicating the diagnosis. Especially when we talk about the diagnosis of dementia, which is a progressive neurodegenerative condition, take a pause. Take a pause at your level also. that, okay, I'm very sure that, yes, I have followed the patient for 3 to 6 months. Now I can see whatever cognitive deficit is persistent and progressive. Now it's, okay, I can diagnose with a dementia, because dementia is such a stigmatizing diagnosis. Once you diagnose the patient with dementia, it's his or her future is a dilemma, because their every decision will get questioned in view of your diagnosis, right? So take time. There's no hurry in making, there's nothing you're not gonna lose the patient if you make a diagnosis after 4 months, especially if you're talking about Alzheimer's dementia, which is very common, right? So take time, communicate with empathy and in an understandable manner. It's very tough, they don't understand, it's very tough even for us to understand that my kith and kin is going to be like progressively in a neurodegenerative state. They will not remember me, they will not remember who we are, where we live, how to eat, how to dress, right? Where to pee. So provide breaks while you're communicating the diagnosis, and if possible, tell them that I think that's getting too much for you for today. We can meet again. We'll discuss about the diagnosis again in 2 days, 3 days, 1 week time, when you're ready to sit and discuss about it. And most important is dignity, consent, capacity, and confidentiality of older adults. Just because they have got old, they might not be having that much value, and we have that ageist attitude in us that everything, whatever is happening to our older adults, we tend to take it for granted as a part and parcel of aging. If they are not communicating, they got aged. They are not moving, they got aged. They are lying on the bed, they got aged. They are irritable because they are aged. So we have to get over this, right? Old age is not a disease. This is what everyone is gonna face in days to come. Might not today, in days to come, right? In 30 years from now, in 20 years from now. So old age is not a disease, it's a strength and survivorship. Triumph over all kind of vicissitudes and disappointments, trials and illnesses. So we have to give due respect to their journey, right? The journey they have taken up to 60, 65 years of age. So if you're not giving that due respect, dignity, taking their autonomy in planning the care, it's wrong on us, not on their part. Then have a periodic follow-ups and feedback sessions. And this periodic follow-up and feedback session depends upon the conditions. If I'm talking about delirium and patient is opting for outpatient care, I'll be having frequent visits like at 3rd day or a week interval. If I'm talking about depression, it's like first consultation after starting a antidepressant medication, I'll try to review the patient at 2 weeks interval, followed by 1 week, 1 month or 2 months, like that. If it's dementia, it's like once in 3 or 4 months. If I'm talking about MCI, which we tend to see, and we follow the patients of MCI also, we tend to follow them at 6 months to 1 year interval. Then support, advice and care after diagnosis, which is very important, especially when the journey is of 8 years, 10 years, 12 years. This is the course of different common dementias. It's a vascular dementia, Alzheimer's dementia, or frontotemporal dementia. So keep educating the patient and care provider at every visits. At every visit, then tell them that you are there to help them. Educate family and patient about the diagnosis, about the support, about what the supports are available in your society. So as a geriatric mental health professional, you have to be vigilant about what kind of NGOs are working, what kind of respite cares are working, what kind of in-house nurses are available which can go and take care of patients when there is no one to take care of them, right? So these things also you have to have a list to help them then and there. And obviously research and education. Pharmacological, there is the basic rules of geropsychopharmacology is we use very limited drugs, because like pediatrics, we have to work with the limited drugs. We have to start low, go slow, wait for the adequate response, at times for 10 cautious when we are changing the medication, because it's same dangerous stopping the medication all of a sudden, especially if I'm giving an antipsychotic and I am stopping it. They are very sensitive to EPS and other problems. What is most important requirement for running a geriatric mental health setup? From my limited experience from 2015 onwards, I can say is the commitment towards the older adults, that I want to work and help them the best possible I can do. Evidence-based practice, because it's not just I'm practicing, so I know from my experience is what is coming up from, you have to keep up yourself updated, what's the current guidelines are talking about, be it IPS guidelines, be NICE guidelines, be APA talking about, how they are talking about older adults and practicing issues. Establish a trusting relationship with your patient and their family that go a long way. Develop mutually agreed upon modes of communication, how you want to be contacted, like somebody likes to be contacted over phone, somebody don't like it, right? What timing they can contact, how they can contact. Work in partnership with various aligned services, like I told that being a geriatric mental health professional, it's how your every senses, how holistically you can see, how best holistically you can see, that will help you. Have a clear roles for everyone, what you gonna do, what your social worker gonna do, what your nurse gonna provide with. And most important is periodic evaluation of the services you are providing. So ensure not just your commitment, but the commitment of the team you are working with. Evidence-based practices, have a trusting relationship, working in partnership with various services, so people will recognize the importance of different pieces of puzzles, be it social worker, be it your physiotherapist, be it occupational therapist, and coming together to form a new paradigm of care. Always remember that all pieces need to fit together to make it work, and that some of the fits are not easy to fit, or can say aren't from that puzzle set at all. Then periodic evaluation, how you can do your service evaluation. You can have as simple as that satisfaction surveys. Like you are coming to us for past 3 to 4 years. What is your experience? How you want us to improvise on our services? You can take feedbacks and you can discuss that in your MDTs and improvise on your services. Then regular audits, what kind of patient you are seeing, what is the attrition rate you are seeing, why your patients are not coming for follow-up, what is happening in between, right? So that will help you to evolve in your services. Challenges, obviously, there's a lot of challenges working in geriatric if there's so less numbers of trained professionals are, because lack of awareness and stigma associated, that old age, it's not very less number of patients, it will not be that rewarding because it's a progressive neurodegenerative field. And you are dependent on a lot of others as well. Poor health seeking behavior, obviously older adults, mostly they don't come on their own that I need help. Like an adult can come and, okay, I'm not feeling well, I'm not able to perform well, at job I'm having struggles, at studies I'm having struggles. That's not gonna happen here. They are already retired, they're resting at home, right? Then there are dearth of specialists, so it's very tough to identify even if they are coming to you, right? Then lack of trained professional, accessibility and affordability. Financial and logistic requirements, as I told you, it's a teamwork. So it's not necessary that to begin with in your team you have everyone, but you can liaise with, right? There's a lot of physiotherapists working in your area. You can liaise with them, refer to them that, okay, my patient is having this difficulties, can you help with them, right? I'm having a stroke patient, depression, he's not able to speak. If he can have a speech therapy, it will improve his quality of life and depression will get over. If he can communicate his feelings, what he's feeling, what is happening to him. So lies with a speech therapist, just tell what you want, because mostly these therapists don't know what is expected out of them. If you give them a targeted thing that this is what I am thinking, can you help me, can you help this guy or female for that reason? So it will be, can get done. Getting appropriate staff for target population, training, requirement and retention of staff from time to time. Gaining trust and establishing how we are different. This is very important. How, like everybody's telling that how you are marketing that you are different, how your online services are different, how your practicing is different. So you have to create market for yourself. You have to advertise that, okay, I am someone who is taking care of older adults and I can take care of them a different way. My care is different from others. I am very holistic. I provide this care, that provide, and it's depending upon how you want to express it. Then the most important challenge is customizing care to meet the need of this heterogeneous population. They have heterogeneous needs and they are a heterogeneous population. You can't have a clear SOP that 1, 2, 3, 4. This doesn't go with an older adult. Then interfacing with the long-term care plan. And this is, I liked it when I was making my presentation that I was reading how best to explain you what is ageism or what is the ageist attitude. And I got this phrase, fallacy of misplaced empathy. It's not that I'm not empathetic toward older adults. It's not that you're not worried that they are not getting a they are having pains or they are irritable. You are considering it, but then you are blaming it to their old age. So there is empathy, but which is kinda fallen, misplaced. So now it's open to discussion.
Thank you, Dr. Akanksha, for a very, very lucid presentation about how to go about caring for the geriatric psychiatrically ill. I think, please sit down. I think one way of integrating a geriatric clinic into a general psychiatric clinic is, probably I would look at it this way: have a 1 day assigned for all the geriatric patients, give appointments on a single day, where if possible, depending upon the number of patients you are getting, you can request a physician colleague or a neurophysician colleague to come along to your clinic. One of the problems in the geriatric cases is that once we ask them to go to different people for different checkups, they get exhausted, and the relatives also feel exhausted. Instead of that, if we can integrate that service under a single roof, if you have a single day of appointments for geriatric population, you can have a psychologist, you can have, if possible, a physician friend or a neurophysician, depending upon the number of cases you have. So the whole workup and whole plan of management can be done very effectively. This is one way of integrating the geriatric clinic into a psychiatric clinic. Anyway, I leave the discussion open.
Very nice presentation, and I would like to bring in a very important dimension to this geriatric population, and which I have encountered. One is that they are subjected to elderly are subjected to elder abuse of various kinds. One of the very important abuse is financial abuse by the people. There is one famous case which had happened recently, and this is what I'm talking about: medico-legal, telepsychiatry, and geriatric population. So one old lady, she was living with her daughter, okay, and then she is a clear-cut case of a dementia. So the whole property and everything got shifted in the daughter's name, which later on was found to be, there was a collision between the family, the judge, everybody was involved in that. Then the other daughter, which was living in US, and she was aware of that, when she came to visit India and she looked at her home, it was not there, it was somebody else's home. So when you have to be very sure when you take care of these people, ask them. Many of the time we assume that they will not be able to tell us, they will not be able to communicate their feeling. I think it's very, very important to talk to them. So when I do telepsychiatry with these people, first of all, I always ask their name. I always. How do I know this, suppose Shanti Devi, how do I know she is the Shanti Devi only? Because many people are, they are misidentifying in order to take many financial claims. Another famous case has happened recently wherein one of the physician was also involved. Physician was not involved directly, that it was all pensionary benefit, and the lady had died 1 year back. And throughout 1 year there was a teleconsultation, which was on record, purposely. And then later on it came out that this lady had died a year back, and they were showing some other lady, and in between they did not show anything, and it was all on the prescription. So when you do consultation with them, first of all, establish identity is very important. Secondly, the camera, like in telepsychiatry, we generally like to face the upper part of the body to talk. When I do with telepsychiatry, I always ask them to show me the whole room so that I can visualize the patient completely. I ask them to please make her or him walk. Then you will be able to, within few minutes, you would be able to identify major issues with them. Then rest of the assessments as far as, I think medico-legally in this particular age group, from mental health perspective, it's extremely important to establish identity and be sure that the patient is alive. Many a time I have seen, no sir, the person is old, they cannot walk, they cannot come to clinic. I say, then I cannot help you. If I need to see a patient, then I need to see a patient. I will not be able to take a risk. I think this is very important. You have already mentioned that.
Even we tend to struggle, so like this patient is on depression treatment. In 2018, they got the treatment. And now in 2023, they will come, that patient is not ready to come. Now you write a prescription. Last time, whatever medication you have written, now they're not giving over the counter. So just you give me a prescription so that he gets settled, then I'll bring you, they will give you 20,000 reasons. So at that moment, we'll document completely that attender reported, came without patient and requesting this, then this patient drugs was issued for particular days, 3 or 4 days, and in 3 or 4 days you try to bring the patient.
In fact, in geriatric care,
So that's
I think from the medical legal point of view, especially if you have not seen a patient,
no, so they are, he is
whatever I would
this is
say,
my follow-up.
Akansha, what I'm telling you, if you have not seen a patient physically or electronically, you should never refill a prescription, because 3-4 days you do not know what happens during these 3-4 days on that particular day. And if you have not taken, even if the attendants are there, how many times we know that he's the real son, he's the real daughter? We do not know that. So I think in my practice standards, I would say I will not write a prescription. This has happened to me many times, sir. I can assure you in the next few hours the person will be in your clinic, because we become flexible. After 4 days again they will come, sir, today we will not be able to bring in. And they manipulate prescriptions. You write 7 days, they will make it 17 days. They will make it 27 days. We don't know that. This is how it happens. So I think, in my opinion, I'm sorry to cut you down over there, but I'm very sure that you should not write a prescription for anybody who has not been seen by you.
in fact, in geriatric care, one of the essential another component of care is home visit teams. You have to have a home visit team if you're organizing geriatric services. That creates a lot of impact in the sense of your services, plus more clarity about the home environment. You may not go, you can send the team in the psychologist or the social worker to visit the home and get back with the details.
Sir, I would like to know from you, Chandrasekhar sir, about inpatient, your experience with inpatient geriatric care.
See, basically, inpatient geriatric care occurs only when there is absolute need. As she already pointed out, that most of the time we try to see how best it can be managed at home only, number one. And it depends upon the inpatient care actually happens in 2 areas. One is either a delirium or delirium superimposed over dementia, or a long-term care for dementia. These are the 3 areas where often geriatric cases are admitted. The other area where sometimes can be severe depressions.
I am asking about long-term dementia care.
Again, long-term dementia care is more of a team approach. You have to have a proper infrastructure, which we'll discuss in the next probably.
Dr. Shanti Mohan. So I have a doubt. You mentioned that in the first visit we try to delay the diagnosis, but practically how far it is feasible? Because we get patients from mixed populations. Sometimes we need to tell the diagnosis in the first visit itself, or ideally it should be conveyed in the first visit itself.
If I'm talking about, see, geriatric psychiatry comprises of multiple diagnoses, any mental health problem that is happening in 60 years and above. And the diagnosis which I'm asking you to delay is about dementia diagnosis, which is a major neurocognitive disorder. You can say that it's a cognitive impairment under evaluation. I'm working on it. I need to look at more bloods, imaging, because we need to rule out all treatable causes beforehand diagnosis someone or stamping someone with. Because stamping a diagnosis of depression it can have a good outcome, right? You can treat a patient with depression, it can come out of depression. But can a patient come out of dementia? How will you justify then if your patient comes out of dementia?
Ma'am, sometimes, especially in the private practice, we may not be able to see the patient in the second visit.
No, you can say it's a cognitive impairment, but requires a workup.
Okay, thank you.
There's no harm in saying.
Boredom in old age. So I have multiple family members who live up to their late 90s, couple of centurions. And let's say I've been with them for the last 20 years. I see them physically age, right? Mentally, I still feel they are in the 70s. I've done ACE3 for a couple of them. They don't have cognitive deterioration. But I usually see, as you, like you said, you ascribe a lot of things to getting old. You give them a newspaper, give them some TV, you give them food, and you expect that's all they need, right? So I'm sure the family doesn't mean to be mean to them, but usually this goes on. Maybe that is the cultural belief that as you grow old, your friends die out, your spouse dies, you retire, the number of things you enjoy tends to decrease. That may not be the case, but do you really bring this up on a, let's say, a routine clinical thing? As a part of your evaluation, do you educate them about, increasing the number of things
Yes.
to engage them, or how do you go about this? That's just
It's a usual question I used to get as a geriatric mental health professional, how to keep myself active to prevent dementia. So it's a physical activation, psychological activation, social activation. So physical exercises, social interaction, as much circle you can make. And it's like you said one line which is a bit like, I have given, provided with newspaper, provided with TV, and I think it's done. It's never done that way. It's like you have to ask them what they want. You are giving what you feel like giving. You feel like they need a paper. I don't know whether they're able to read properly or not in their 90s, right? You have given them television, whether they enjoy television or not, because they are from the era of a radio, right? Whether they enjoyed that television or not. So it's how much you can involve them in their care. What you want to sit with someone, you want to visit somewhere, you want to sit in a temple. It can be anything. So take them in confidence, then you will get to know that what they want to get over their boredom. It's not us, because maybe something is good for me to get over my boredom, but may not be good for you, right? I may like politics, you may like songs.
do you bring this up as a therapeutic thing with the family every time?
Because if I'm seeing a depression, I need to charge something for them to keep them activation. Behavioral activation, how will you do? Right, behavioral activation is equally important at your pharmacological management, right?
And do they accept it? Like,
Yes, they do.
They do change.
They do, means I'm having a patient who is a retired vet. He was director of Chennai Institute of Veterinary, and then he's a known case of bipolar. He retired, he landed up in depression, bipolar depression, and then he was not able to come out of it. It's like, what I have to do? There's nothing I can do. I did work there, I'm retired now, settled in Lucknow, I don't know, I don't have friends. Then we have to make him get involved with NGOs working with animals. You don't need money because government is giving you good enough pension. But your services are there, your cognition is there, you can use that. Not for others, not for financial benefits, just to keep yourself physically, mentally, and socially active.
Just one last thing. So for patients who are like bed bound, have you ever tried using these virtual reality techniques where there are virtual tools so that they feel that they're getting out of their home?
No, first of all, we need to know that why it's bedridden. There can be a multiple reasons for being bedridden, right? So depending upon the reason for bedridden, we have to plan the management strategy. It can be because of delirium. So task will be like, they don't harm themselves or harm others in delirium. Right? If it's severe stages of dementia, like they can get bed bound in severe dementia, late stage of dementias. So you need to make out what is the reason for that and what the options you are having. That's the beauty of this kind of medicine. Like you have to tailor something different for everyone. You can't have a 1, 2, 3, 4 approach. Every patient will come with a new challenge. You will try something new. And that's why you need to have sessions, multidisciplinary team meetings where you can share your thing. That the patient was like this, I did this a small thing and it helped, right? It can be anything, and your maybe one patient trial can be effective for others 10 as well, right?
Speaker Dr. Akanksha for delivering a very excellent lecture on this particular topic and the interactive audience. Thank you. Hand over to the organizers.
Thank you, ma'am. To the speaker. I request the speaker to present the memento to Chairperson Dr. Chandrasekhar sir. I request the speaker to present a memento to Chairperson Dr. B. Anand sir. Thank you to the speaker and the chairpersons. Stepping into various services, our journey takes an intriguing turn towards the organizational aspects of psychiatric nursing homes. This session promises to be a dynamic exchange of ideas and experiences, guided by our esteemed moderator, Dr. Chandrasekhar sir, consultant psychiatrist at Asha Hospital, Hyderabad, Telangana. Welcome, sir. To introduce the distinguished panelists who will be sharing their expertise. Starting off with Dr. P.K.N. Chowdhury, sir, consultant psychiatrist and director, Chetna Hospital, Secunderabad. Sir, Professor and HOD Psychiatry, Pratima Institute of Medical Sciences, Karimnagar, Telangana. Welcome, sir. Lastly, I invite Dr. Ravulapati Satish Babu, sir, Professor of Psychiatry, Mamata Medical College, Khammam, Telangana. Pleased to have you, sir. These experts bring a wealth of experience in establishing and managing psychiatric nursing homes, contributing to the holistic vision of mental health care services. Let's warmly welcome our moderator and panelists as we prepare for insightful discussion.